We kind of saved the best for last here. I'm really privileged, and I consider myself very lucky to be able to work with our next speaker. And for me, this course kind of has a lot of personal friendships and meaningful relationships that I've had for many years. And both Pat Johnson and Jens Chapman, I would say, are two of my kind of heroes, both in med school. And when I was a resident, I remember I did a rotation at the University of Washington. And just like Pat, there was this army of med students, residents, fellows that was following this orthopedic surgeon on rounds. Even the neurosurgery residents were like, every time Jens Chapman walked by, they said, "There's Dr. Chapman." So they would go and join rounds because he's just an encyclopedia of spinal knowledge, tons of experience. He actually did his fellowship here at Harborview. I think he was Paul Anderson's first fellow, and he stayed on. And I remember as a medical student, was doing a rotation, and I was interested in doing spine, but I really wasn't sure what I wanted to do. And both Pat and Jens had a huge impact on me as a resident. And then I remember even Jens came over to the University of Virginia as a visiting professor. And I just, really admire both of these two guys tremendously. And I remember when I came to town, Jens had the Seattle Spine Summit for like 25 years, and it was the best conference. I went, he's just trained everyone, all the fellows, really pioneering surgeon. And honestly, I've traveled all over the world. There is, to me, there's no better spine surgeon anywhere in the world than Jens Chapman. This guy has done, you name it, he does it. And even to this day, pelvic instrumentation, a lot of the basic principles in AO, Jens put together in the AO knowledge forums, and the list I could sit here and talk for an hour. And I've been so lucky to work with him over the last 10 years. He's taught me so much just about spine, dealing with complications, doing really tough cases. I learn from him all the time. And this is a great talk that he's given multiple times. We kind of do it every few years. And one year we had a bunch of hoodies with actually the 10 Commandments on the back. So I'm really lucky and honored to work with Jens, and he's really a terrific lecturer and speaker, and he's going to give my favorite talk of all time. So Jens.
Those who know me know. Thank you, Kojo. That I don't like this adulation, but I'll take it anyways. But I really appreciate it, because I appreciate the us. And I'm going to get ready for this talk. We have a handout. So it's a little bit tight. Anybody know who this is? Message to Garcia. This is a Dr. John Jainism. This is something you got to know. It's a silly little booklet about a fake episode, probably glamorous, about the Spanish-Cuban-American War. But it was a very telling tale about somebody did something and did take the all-important communication to somebody under adverse circumstances without deliberate instructions or a lot of kind of back and forth. This is something I don't know. We have a Friday morning thing here where we have either... there he is, Neil. Did you get your responses back? Yes. So we on Friday mornings have indications. We have two little vignette things. They're about 5 minutes long, 5 slides. Message to Garcia is something that you got to know. When we discover something like what are the sclerotomes in the cervical spine and how do they relate, this is something, and they don't know it. 5 minutes, you're going to non-punitively talk. This is your message to Garcia thing. Sclerotomes of the C-spine. What do we need to know? Boom. We have a nice version. It's called the Letters to Atticus. This is the Cicero to Seneca kind of deliberations. If you have some musings, some cool observations, That's the kind version. Again, 5 minutes. That's the premise. You guys have witnessed that many years. So we have a handout for this because this lecture is, and this is the wonderful Linda and the wonderful Alexis. And they're going to be our human canons, and these are all medium. Yes, it's just a wee bit snug. I was never medium. Here they go. We have handouts. Here, Charlie Sanser, help throw. Who has a good arm? We need some more arms here. Rod, let's help throw. Help throw, help throw. Help throw. Help throw. If you turn them around, we don't have enough for everybody, so we had to do the random generator. And this is a great occasion to again say how cool it is to get to work with Alexis and Linda. Working with many societies. They have huge staff, and we have basically, and I need to add Gary to that also, a very small group of people who are smart and motivated and just make it fun to come here. And that's what it all amounts to. So the commandments back here are not what I'm going to talk about because, as usual, my brilliant colleague and bestie, Dr. Skuyan, has modified it, and I'll leave it up to you to decide where the modification is. It's so cool to be here with a full house again, especially after the trials and tribulations of the COVID years. But your interest, your dedication really shows that you're going to make a positive difference. And again, the real power of positive is what you see, like Koja is one of my favorite people on planet Earth. This is, and Arjun, I mean, there's so many cool people here. And they have this weird thing in them, just like Alexis and Linda. They want to make a positive difference. And yes, it's a privilege to be in this job. And yes, it's so cool to kind of be together. So our goal is to help you, because you already have all the gifts, be the best spine surgeon on planet Earth, optimize your potential, and execute perfectly for every patient every single time. It's the pro athlete. It's the batting average expectation. It's not 300. That's MLB, and you get tens of millions of dollars a year for that. But it's really, you want to do this with 1,000 batting average. And I love this NHS initiative, and one of our good friends and frequent speakers here, Mike Hutton, leads that as a spine surgeon, getting it right the first time. And this is what this is all about, trying to just make this happen. You've had, I don't know how many millions of data points and tips and tricks, and a great lecture by Dr. Liz Lord right now to exemplify that. But this is a really big deal, because ultimately what we should be driven by is efficiency, precision, and compassion for the patient. That should be the driving three forces of everything. And the reality is, Murphy's Law is very unforgiving. This is the cool thing about spine. This is why I went out of trauma surgery into spine. It is a daily, a minute-by-minute challenge. Any little misstep in your assessment, planning, execution, post-operative management, it will backfire, despite best efforts. So this is, again, by the way, this came from the fourth law of thermodynamics. So if you want the source for Murphy's Law, this is actually a highly natural scientific text. I always think this is very important to realize that. And again, the awards for malpractice have gone and followed the professional sports leagues. They're getting crazier and crazier, have lost any reality, but this is the reality. I find it obnoxious to give books for Christmas and holidays, but I do it sometimes. But I just like a couple of philosophical texts that I find very helpful. One is essentialism, so cut away the clutter. I have total ADD. For me, this is a survival strategy to try to always hone down in an almost spiritual sense on what is really necessary. I found this to be a very helpful book. And Rod, independently of this one, I gave it to him and said, oh yeah, I just bought this also, it's a good book. Everybody shows you this book by Jim Collins, and this is actually a very, very good read. Everybody says they've read it. I reread it ever so often. But I'm going to show you the pyramids here, because really what matters is that everything counts, and especially the foundations count. This is where the pyramids come in. Every one of those foundational stones matters, and nothing is too trivial. So don't be disappointed. Again, you can see the 10 Commandments somewhat resembled here. But these are foundational blocks, and they should not even be a complex thing. They should be just something that you kind of stepwise go through. And yes, in the OR, I'm an obnoxious nerd and go like, it's a violation of Rule 3. But yes, they do matter. And 10 Commandments, we all know this is kind of a simple way to kind of look at things in a very classic fashion. Nobody in this room probably knows who this guy was. He now wears a Santa Claus beard. But for our generation, I'm looking at Patrick and myself here, this was a big, big nighttime presence. This is an AO slide. Again, these 10 spine commandments all mean to kind of provide obvious, simple trivialities that kind of have a bigger backstory. And I think if you do those, you'll actually be quite a successful practitioner. So I hope you'll not see them as petty little marginalities, but something that are really foundational things that will make you all happier. And for me, I have a couple of serious heroes, and literally the faculty here are heroes of mine. But one thing that I've always seen as a pattern is a calm, organized, passionate healthcare delivery. You will not see Dr. Arjun Sebastian yelling in the OR. I've not been in the OR with him, but I cannot imagine that remotely, right? Richard Chua, one of the coolest cats around, and despite his frustrations with trying to navigate through MIS, I'm just joshing here because he's a cool cat. I know that from our shared fellows. There's not a yelling, short-tempered interaction whatsoever. And you just heard Liz Lord again, very cool, very calm the OR despite very significant and challenging cases. They're passionate, they love what they're doing. And for me, the total hero is Professor Majid Sami and John Jane. They practiced into their 70s, into the 80s. Dr. Sami, how old is he now, Rod? 80? 84. I watched him do skull-based surgeries at age 80, and it was a cool, calm OR, the same thing all the time. Did the most delicate skull-based surgeries, most unforgiving thing, right, Patrick? I mean, nothing wrong. And just everybody was happy, calm, pleasant. He must have listened to Dr. Dave Skagg's lecture, or just known it. So the foundations are so important, but only operate on the right patient, the right time, to the best of your abilities, at the right location, at the right time. Don't ever be too busy to double, triple think. And what Dave said, I mean, we had this in the OR just the other day. Everybody's mind counts. I'm so grateful for Gautam. Hey, this guy has true 6 lumbar vertebrae. How are we going to localize? So cool. Every eye, every mind counts. Every double and triple check is an advantage opportunity. What we don't do anymore in spine, and this is a clear MIS lesson, is we don't do Columbus surgery. We don't go exploring around the spine. Patients always ask me, if you're at C5, 6, I'm going to do C6, 7, also I'm going to look around. No. I'm going to do C5, 6. I'm going to do it very precisely. So preparation, mental preparation, and then focus, laser-like, whatever the pages are, you're going to look at that image, you're going to look at it one more time. Am I left, am I right? Am I left, am I right? Am I left, am I right? We're left. I actually mark my patients, and if it's a laterality surgery, I'll write it down onto the patient, not just my little JRC scribble. So use that. Positioning. This is, again, so elemental, right? Wrong. If there's something wrong with a patient in their positioning, if their abdomen is compressed, if they're laying on their chin, this will all turn from a routine surgery into a complete cluster F, and I'll let you guess what the F stands for. By the way, I've had PION, posterior ischemic optic neuropathy. I hope you never have it. I had 3 patients in my life. And it is probably in part positional. If the eyes are below the heart level, these are larger, especially male, and they're larger volume exchanges, and there's hypotension, that's a bad setup. The eyes above heart level or not, you'll never forgive yourself. You'll have nightmares. And I had that about one of my patients where this was probably not well enough addressed. I let it pass. Not cool. So these are classic things. And when you do the preoperative imaging, there's so many little things, but the throat should be clear. The pressure points should be done, all obvious, but can you see what you need to see? One of my pet peeves, EKG leads over where you want to be. I swear to God, we somehow had a knife blade break off during a TPLIF at L4-5. There's an EKG lead right over that. We had to fish it out. We fished it out from the back, but this knife blade took a life of its own, of course. And the EKG lead over the patient did not make it easier until I basically crawled on the table, took that off, replanted it. But this should be a no-brainer. You should see what you need to see, especially in MIS, without any problems. And head clamps, we've had whole head clamp labs here. They shouldn't fall off. And by the way, Rod changed my life because I've almost gone away from Mayfield clamps. GW tongs usually work. Another crazy thing, Chapman, basics. Don't drape yourself out. Upper thoracic spine, classic draping out thing. You'll drape to the cervicothoracic junction, big mistake. I could rhyme and riff with a queen here, but I'm not going to do that. Because what you want to do is you want to drape to the cervical spine, actually to the occiput. You need access from that top end. So this is a classic thing because I don't want to hear the lines of, we prepped it underneath the drapes. Nah. That's not right. Right, Patrick? This is crazy. Drives me nuts. Sorry. And again, your field should be draped out and very clean. Exposure. Again, I know that especially in the beginning of the year, sometimes with conventional open surgery, the whole surgical premise was blown up because, and I hear these stories, and I do some med mal also, there was an over 2-liter blood loss and a 4-hour exposure because the attending was in another room. And you know what, you can't do a surgery at that point in time anymore. That's probably not gonna fly. You have to adjust and stage or whatever. But 2 liters, 3 liters is probably where the physiologic boundary from something that's doable changes into a highly pathophysiologic shock-like condition for the patient. And there, of course, for the lawyers who watch this, there are exceptions to this. There are clearly high volume blood loss procedures that are planned and where you do physiologic calibrations, but for a routine or relatively routine elective surgery, boy, at 2 or 3 liters, you want to really stop. So you can change the whole premise by doing intelligent and clean dissections and only of what you really need to do and see, and you preserve the ligaments. You don't hack apart in other areas, and again, no Columbus surgery. Dural tears, you heard a great discussion by Liz about what to do about them. For me, this is again one of those discipline things. Preparation. You know where there's a posterior column deficit. You know where there's a spina bifida. You don't want to start the case by having to do a dural repair or reach under something if you can at all help it. It's not, in my eyes, it's a complication. I list it as a complication, even if it's a 2 or 3 such thing. I had a dural tear in an IV drug abuser the other day that I caused, and I repaired it, but I listed it as a complication. The patient's doing fine, but I was unhappy with how I kind of rushed at that point in time. It was avoidable. So again, this is just shows anticipation and execution. And by the way, crosslinks and larger surgeries are a great posterior column reconstruction thing because it makes revision surgeries, which is one of my daily activities, much easier. Number 6 is a weird thing, but especially as I hear about more tech being used, aquamantis and harmonic scalpel and this and that, the cable salad on your table will very rapidly get out of control. And I personally feel defeated if I just even hear that a bovie fell down or a sucker went down. Why? These usually happen because you are not organized enough as a surgeon to put it back into its spot. And cable crossings are a classic problem for this. How do I solve this? I can't always solve this, but I ask my scrub tech, hey, can you disentangle these cables for me? Because I know that the entanglement when I'm in a rush, or I allow myself to get in a rush, will lead to drops. I was at an institution where the drop of a midas led to about half-hour plus, because we just didn't have that many, delay of surgery, or we had to improvise. We didn't have that many. So for me, this is still one of those things of I don't want to drop anything if I can at all help it, and it's just a really big deal. And you'll be so much happier because all of a sudden you'll get that flow state that Dr. Skaggs talked about before. No cable entanglings, no messes and all that. So the next thing, Rule 7, so no cable messes, sorry, no crossovers, no spaghetti. Number 7, that's near dear to my heart. You do a brilliant surgery like what Dr. Johnson does, and the sponges are off. I don't like this one bit. And I see this a lot, and that's cottonoids and sponges and instruments belong in only one of 2 places, in your hands or on the back table, meaning the Mayo stand. And putting them just down, dropping them carelessly somewhere, that's an invitation for disasters. The biggest risk are half by halves, and again, I just feel terrible if at the end of a case, the entire staff of the OR comes together and has to pull out and go through the cell saver, suction sieves, and pulls out trash bin after trash bin. It's terrible. And it always leaves you with a feeling of, I did something that I could have avoided. You avoid this by having a totally organized hand and pass-off thing, and you note this rule: sponges and cottonoids don't belong on the table. And yes, I do have a attending exemption. I sometimes keep a ball probe on my field on my side when I check on screws. And this is where we usually play a song by an artist that was not known to anybody in this room outside of the people born before 1960, and that's Paul Simon, Slip Sliding Away. And the lyrics are very clear, but you never want to slip and slide and plunge. And these are the lyrics of this, and these last 2 lines I really find are so important. And how do you avoid it? You can't totally avoid it, but you have some discipline. You don't start a high-power drill on soft tissues. You always start off bone, and you just know of the power of tools. And so this is one of those things, and you internally want to just check yourself. No slipping, no sliding, no plunging. Ask for help. Have somebody hold a Penfield 4 or something if you're close to dura, or use a cottonoid. Rule 8, the power rule. If you, especially as a younger surgeon, do power moves, have two hands on it. Have somebody actively assist you so that you can use two hands. Pedicle finders. I had, in my earlier years, a fellow plunge in a very nice lady at an L4 pedicle and all the way down to the heft. Why? Because that young fellow was pushing too hard. I let him push. It's my fault. Tap, tap, and gentleness and understanding the forces that you use and not over-forcing what is a hard thing is so important. So the two-hand power rule will guide you well, and Dr. Skaggs has great technological advancements to kind of make this a little bit more controlled. But curettes are a cutting tool, and they're frequently misunderstood. So plunges, slips, skips, register those as hopefully near misses and seek to take preventative measures. Number 9, appearances matter. I actually give my patients routinely a printout that has my name on a floor shot or something to take home. I want the x-rays to look nice. I can tell you one thing, the x-rays that look nice will probably also do well. Chris Shaffey actually totally agrees with that. If you have a nice looking x-ray like what Dr. Johnson showed the other day, those patients probably will do pretty well also. But certainly it's the best business card in the Western Hemisphere. They can have a nice looking x-ray, they can hang it on their fridge with your name on it, and everybody will ask them, how does this look? And by the way, that goes into closures also. If you have nice, cool closures, everybody will congratulate that. If you have a sloppy big scar plate, nobody will like that very well. They'll go like, this was a Slaughtermeister. So this is a big deal. And I'm not sure what to think of these patients who've had like 18 incisions for their scoliosis percutaneous fixation. I'm not sure that they're aesthetically pleasing. But that's just my own statement. And by the way, I give out my x-rays just even for my decompressions. I document visually where I was, which side I was on, and I have an image for them, and even they have then a nice image where they had their surgery done. They always love to see that. And this is the most important rule, and this is where we'll come to a close. This is the no hurt. Nobody gets hurt. Nihil nocere. We all know that from the Hippocratic Oath, which, by the way, did not come from Hippocrates. But basically, we have vulnerable patients, we have tall challenges, we have big challenges like this patient. It's a very unforgiving field, but it actually goes beyond that. It goes to the people who work with you. Nobody gets more radiation than what they should have, and when you pass off that next sharp instrument, use the things. Who's watching the TV show Bear, by the way? Anybody know of that? Pretty cool show. How do they interact with one another? They have clear precision magnet, hot, behind, stuff like that. Next time you pass a sharp tool off, flip it around, take that split second and have the blunt side first. And when a sharp tool comes across, there's sharp, sharp. Hot bovie doesn't go on the OR table, it goes back with a thing, hot tip. I know this sounds funny coming from a German because we have such a soft language skill, but guess what? The predicament of not hurting anybody goes to somebody else also, and that's you and your loved ones. Don't hurt yourself. Don't hurt yourself. Take care of yourself. I'm not going to read through this, but these are very important lessons. Take care of yourself like you take care of others, and everything will be much better. So do love yourself. Do take care of yourself. Whenever I hear Dr. Skaggs speak, and again, I think it can't be said enough, what I really envision in an OR and what I've seen in Dr. Sami's OR and Dr. Jane's OR is a flow state. There's a calmness, there's an efficiency, there's a meaningful interaction, there's no garbage taking place, there's no whatever metalhead blaming going on mindlessly. There is a collective spirit that drives everybody, and I personally think that I'd much rather hear Dr. Skaggs talk than Daniel Pink, who's a great speaker in its own right. But I think Dave Skaggs is our David Pink drive, so thank you. So this all culminates into, you see phenomenal people and human beings here, and you're part of this family now, whether you like it or not. But keeping calm and loving what you're doing, that's, I think, the best thing. This is what I found so inspirational about Rod and about the legions of people who have grouped around him. I'm one of the Rod Oskuyan groupies, as we all are, and we are all doing this in the spirit of Dr. Jane and others. So hope you take magical memories from you and the Philadelphia-Pittsburgh exchange. It'll go down into the spine trauma world now, I think, in December, to see those two spar against one another. But thank you for being here, and thanks for listening to this.